As you take your seats, I want to communicate something up front, and that's that this talk is not about me. It's not about GetWaivered. It's not about MGH. This talk is about you. This talk is about a story of how an individual saw a problem and didn't take no for an answer. And I want you to learn some of the things that we dealt with so that when you get out there and you start advocating and you start pressing for change and you start hitting some of the resistance that I hit, it won't come as a surprise to you. So before I begin and tell you about Mass General's response to the opioid epidemic, I want to tell you a quick story. So I was in my first month of my first year as a doctor at Mass General Hospital, and it was 2 a.m. And I had a woman come to me who was in her early 30s. 6 weeks before she came to see me, she had fallen down the stairs at her son's daycare facility. She broke her ankle very badly, had a very, very deformed ankle and had to go and actually get an operation. She was discharged from that hospital with oxycodone, enough for 2 weeks. What she found was that after the 2 weeks were over, she could not feel normal without taking this medication. She was taking some from her cupboards and kitchen cabinets, and eventually from her friends and family. It got so bad that she actually got a dealer back home in her hometown of Weymouth to actually sell her opioid pills. That night, though, she had made a decision. She wasn't made for this life. This wasn't how she envisioned her life being. And so what she did was, she did a brave thing. She sent a message, a text message to her dealer and said, "That's it. I'm done. I'm getting my life back together. Erase my number." The dealer said, "Okay, good luck." An hour later, she heard a knock at her door downstairs in her apartment. It was her dealer. Because she was such a good person, and because he knew that the road would be hard, he wanted to give her a parting gift. 10 teal oxycodone tablets for the road, for free. She took the pills. Her husband saw this and intervened, and that's when they knew that they couldn't do this alone. So they started calling places and looking for things online in Massachusetts, and nowhere was open. They couldn't get help. So they came to the emergency department. And guys, when I heard this story, this is my first month as a doctor. I hear this story and I think, well, this is a person who's here for help. I couldn't wait to get her treatment. I'm hearing her story and I say to her, of course we're going to get you help. I didn't know what help meant. I had no special training in addiction nor in opioid use disorder, just like every other medical student in America. See some heads nodding to that. And so I told her, we're going to get you your help, don't worry. And I go and I tell my boss, my attending, hey, look, we've got this woman and we have to do what we can for her. I want to admit her to the hospital. I want to get her a specialist. I want to get her whatever treatment means she needs it. And he said, Alister, that's all well and good. That's just not how we do things here. Guys, that walk from my attending's desk back to her room was the longest walk I've ever made as a doctor. To leave the room with such hope that we could make things better for her, and then to return and say, not only do I not have an answer for you, but I have to discharge you from the ER now. That felt unsatisfying to me, and that's how I got into this work. And as I learned more, I realized that it wasn't just me. ER physicians all across the country were dealing with this and struggling with this. In a poll done in 2017, we found that 87% of ER doctors said that this opioid epidemic is not getting any better. In fact, it's probably getting worse. And it's no wonder, you look at the data, over the course of the last 10 years, ERs alone have seen a 100% increase in the amount of presentations for opioid addiction. That's more than any other clinical setting that we know of. To compare it, on the inpatient side, 60% of visits, we've increased 60% on the inpatient side. When you ask ER doctors, how do you treat opioid use disorder, here's what they say. They say, we do detox and we do abstinence. 93% of them say that's the way you treat this medication, you treat this disease. The problem with that is that it doesn't work. We've got lots of data that says that detox does not work. This is just one, a randomized control trial that segmented folks into the detox group versus the medication group. They looked at folks over 365 days a year. And what did they find? No one in the detox group stayed in recovery. In fact, 20% of them were dead before the study period was over. You look at the medication group and 75% of folks stayed in treatment. I'm here to tell you, if you don't know this already, we would not accept this for any other medical disease. If this were cancer, and your loved one had the choice between treatment A and treatment B, and treatment A was detox, would you stand for that? I wouldn't either. So we know the detox doesn't work, but what does? We've heard lots of great information. Dr. King spoke about this. Partial mu opioid agonist, buprenorphine, has an overdose risk that it's minimal. It's paired with Narcan, so the misuse potential is low. And we've got 30 years of research from the addiction community that demonstrates that buprenorphine saves lives. Other folks at this talk, at this conference, have been able to give a much better presentation with regard to data, but I want to tell you a little bit about the data. This is what we saw in France. When France decided to liberalize the way that folks were able to prescribe buprenorphine, primary care doctors were able to, in the mid-90s, finally prescribe buprenorphine without any laws restricting it. They were going through a heroin crisis of their own, and they needed to do something creative. What did they find? 80% reduction in heroin overdoses, just by that one policy decision. We have data that shows that buprenorphine in the ER makes a difference as well. We've randomized folks into the buprenorphine group and to the control group, which is, quite frankly, a sympathetic pat on the back and some discharge paperwork. And what we found was that when you check in with folks a couple of months later, 78% of them are still in treatment. When you compare that to the control group, 37% of them are in treatment. This is astonishing in terms of the difference between these two results. Normally in medicine, you have maybe a 2 or 3 point difference between different types of treatments. Here we find a nearly 50% or over 50% difference. So just to summarize the problem and get us up to speed, what was the problem that we were dealing with? Number one, the opioid epidemic was getting worse in EDs. Number two, the treatments that we had were limited and ineffective and, quite frankly, not evidence-based. And number three, that buprenorphine is effective. We have got good data, but no ERs were providing it. And so what's the solution? The solution was ED-initiated buprenorphine at Mass General. But as with any change, we ran up against challenges and resistance, and folks who said no, and folks that didn't understand, and folks that said, well, this is not a disease that we treat. The challenges came in 3 forms for us. The first is current federal law. And behind every one of these challenges was a hidden doorway to an opportunity. The opportunity behind that current federal law challenge was this GetWaivered campaign, which we'll talk more about. The second challenge was there was no buprenorphine protocol that we could just sort of grab off of a shelf and put into our ED. It didn't exist. So the opportunity there was for us to create one of the first ED-initiated buprenorphine protocols. And then the third challenge, for anybody who's ever had a New Year's resolution, you know changing behavior is hard. Now, changing clinician behavior is even harder. They say you can't teach an old dog new tricks. Well, you can't teach an old physician new ways to practice. Often, the way that physicians practice are 30 to 40 years old because that's what they learned in medical school. So the hidden opportunity there was to blend behavioral economics and to blend addiction medicine in a way that we can create a new habit for physicians when it comes to treating opioid use disorder. We got a grant from the Arnold Foundation to do that. So challenge one was this current federal law. Raise your hand if you've heard of this Data 2000 Act. Got one there. Oh, this is going to be fun. Okay. So you can't imagine a worse system if you wanted to take care of individuals with substance use disorder. That medication that we talked about, buprenorphine, how evidence-based it is, how better it is than the alternative. For a physician to prescribe it, if I wanted to prescribe it and I didn't have a DEAX waiver, my license would be revoked. I cannot prescribe buprenorphine unless I have a DEAX waiver. But I can prescribe morphine and fentanyl and oxycodone without any extra waivers. Isn't that a little strange? Yeah, I'm hearing some uh-huhs. I agree with you. Now, how do you get that waiver? It's clear that you have to do this waiver training, but how do you get it? Well, not only do you have to get a waiver, you have to sit in a classroom for 8 hours, and they make you pay for it. $200 to get this waiver training course. You talk about the barriers and the roadblocks to getting folks involved and interested in treating. This is how you disincentivize people. So that's the challenge. Now, I gave you a little hint there. If you guys could imagine a number between 0 and 100 in the United States for the number of ER doctors that have their waivers, where 100% is every ER doctor and 100% is no ER doctor, what would you think about that number in your head? I'm hearing some 20, maybe 30. Now remember, hold on now. We have, right now, an epidemic that's killing 140 people a day. Think about that number. But then consider that we have an epidemic that's killing more patients than we had an HIV/AIDS epidemic at the height of it. Now think about that number. And what do you guys think? Shout it out. Someone saw the slide. I heard some 20s and 30%. It's 1% nationwide. This is why our system isn't working. So that's the challenge that we had. So the opportunity here that was behind that challenge was to create the first ever GetWaivered campaign to nudge ER physicians to get this waiver that allows them to unlock the ability to treat patients that are coming to them asking for help, like that woman came to me asking for help. So at the start of our campaign, we only had one doctor in our ER who had this waiver. Had 42 other doctors, or 41 other doctors who did not. We recruited a team of designers, public policy students, physicians, behavioral economists, and we designed a behavioral economics framework. And the goal of it was to get clinicians to voluntarily choose to take this course. No one's arm was twisted to get them in. It was not an involuntary thing. There was no mandate. We just wanted people to come to the decision that this was a good idea. So we created a website that simplified the process. It's really, really difficult for the physicians or the nurse practitioners or PAs in the room. Rich, we were talking about this, how difficult it is just to find where do you go on the website to get a waiver. It's very challenging. So we made it very straightforward on one simple page. We recruited addiction specialists to come and teach our course. We brought patients who were former frequent flyers of our ER, who we hadn't seen for many years. Most ER doctors thought that was because they were dead. It wasn't. It was because they were in recovery, and they weren't in the ER. We brought them back and had them tell their stories. It was a beautiful moment of sort of reconciliation between both. We brought a physician who was a primary care doctor at Mass General Hospital who had opioid use disorder himself. He wrote thousands of pills worth of prescriptions to patients that did not exist. He lost his practice, he lost his license, and he got it all back by starting first with medication therapy with buprenorphine. And we're proud to say now that he is an addiction medicine doctor treating patients at Mass General Hospital. He came and told his story to our physicians. And we made it fun, guys. At the end of every one of these waiver training sessions, we had a pinning ceremony. Every provider had a pin, or was given a gold pin that they put onto their white coat. That is the chair of the addiction service of Mass General Hospital, putting a pin on our vice chair for emergency medicine. This is our chief of the department, the most influential individual in our department, and they were among the first groups of individuals who we got to get waivered first. We invited local media to come and do a story on the GetWaivered pinning ceremony, and we had some nice positive press about it. which basically all helped us make the argument that, look, this is something that not only is the right thing to do, but everyone's doing it. The idea is to make doing the right thing observable. And we celebrated folks. At the end of every session, we spread pictures of our waiver training sessions on social media, on posters, on flyers. And at the end of the campaign, 40 out of 42 of our physicians at our department now have their waivers, 95% of our department. And you compare that to 1% nationwide. The NIH has featured our campaign as a model for other hospitals to use with regard to moving to a place where we can treat opioid use disorder in a holistic way. And most importantly, thanks to the incredible force of nature that Dr. Jennifer Potter is, we've partnered with Texas to first do this on a statewide level. And because everything in Texas is bigger, you guys are now, it's not just 40 physicians. This is thousands of physicians that could potentially be waivered because of this amazing effort that's been started by Dr. Potter and by many of you all in this room for creating a space where we can have these kinds of conversations and where we can build on the framework that many of you have laid in this state. So now the second challenge here is that we didn't have a pre-existing buprenorphine protocol. Okay, great, you've got everybody waivered, but what do? Back to Dr. Potter's question. The waiver doesn't matter if you don't use it. And so our opportunity here is to create the nation's first seamless ED-initiated buprenorphine protocol. So we wrote academic pieces about it, policy position pieces, and then we launched our protocol. And here is that protocol. 3 important points. Number 1, 24/7. It doesn't matter who you are, where you came from, what kind of insurance you have. You get access to medication treatment on demand. Number 2, every patient gets a to-go pill pack if they are not in withdrawal. What that means is we get the medication from pharmacy and hand it to them with their discharge paperwork to begin their recovery process. And the pharmacist talks them through what it would feel like to be in this stage of withdrawal, and then you take this amount of medication, and then you take this amount of medication, essentially talking them through the induction process. Oh, and by the way, it's absolutely free for patients. There's none of this having to go to the pharmacy with a prescription and then things get lost and you don't know how things are going to turn out. We know from our data that ER prescriptions, this is terrible to say, I don't know if there are ER doctors in here, but 50% of the prescriptions that ER doctors write are either not taken or not filled. And that's in the population without opioid use disorder. So you talk about one of the most difficult diseases to get a hold of to manage, opioid addiction, and you wonder what would happen with that number. It would probably be even less. And the third piece is everyone gets next day follow-up in our specialty clinic, our addiction specialty clinic, 365 days a year. It's important to state this. This is just new. Our protocol, MGH ED-initiated buprenorphine protocol, and the work of GetWaivered is now state law in Massachusetts. So this is Bill 4742 that the governor of Massachusetts, Charlie Baker, in August signed. What this means is that now 80 hospitals around Massachusetts use our protocol or are beginning to build a protocol like it. Drilling into that for a second, that means that if you're in Massachusetts and you walk into an ER, the hope is at some point in the near future, they've got about a year to put this in place before the federal regulation kicks in, you will have on-demand access in our state. Now, challenge 3 is that changing clinician practice patterns is really, really hard work. Creating new habits and unbreaking old habits or breaking old habits is really, really challenging work. But there's an opportunity here, and the opportunity is to use behavioral economics, some of those same nudges that we're using to get patients, to get providers to decide voluntarily to get their waiver. We're using some of those same interventions to help them make the decision to, yes, we should definitely give this patient medication in the appropriate circumstances. So we've partnered with Ideas 42, which is a design and consulting nonprofit, a behavioral economic nonprofit. They've worked with the White House before, the City of Chicago, American Express. And thanks to the Arnold Foundation, we've gotten a large grant to basically help us create a collaborative process together. And the process is aimed at this question. What are the barriers to physicians adopting a new opioid use disorder protocol? And this is a question that many hospitals now in Massachusetts are thinking about. They're all creating this new protocol, but what happens when you put it in and no one uses it? Or what happens to the hospitals here in Texas when we get folks on board and no one actually prescribes a single dose of buprenorphine? For folks who work in organizations in this room, you all know that protocols get rolled out, and often no one uses it. Often it's the only person who knows about the protocol is the one who developed the protocol. Emails just don't get open. So how do we overcome that? The way we overcome that is by doing this process. We do decision action maps. We walk through every single decision and action that follows for a provider who's thinking about helping a patient with opioid use disorder. The same thing for patients. We walk through every single decision and action that follows for patients that are thinking about disclosing to a physician, hey, look, I know I'm here for my ankle pain, but actually, the problem that I really need help with is the fact that I want to get into recovery and I don't know how to do that. Here's what we found. We interviewed a lot of people. It was very important to do this, and we learned a lot. Here are the 4 barriers we came up with. Number 1, many of our physicians and nurse practitioners and physician assistants were saying that the protocol was not easy to remember or access. The second is that they said that there were a lack of cues to initiate the conversation about opioid use disorder. The third is that they said it was not top of mind. It's a busy environment in the ER. And then the fourth was that it's sometimes an unclear responsibility with regard to who's supposed to treat this. Is this a social work thing? Is this a psychiatrist? Is it the primary care's responsibility? And so this is just a brief snapshot of some of the solutions that came out of that process, targeted at each one of those barriers that we heard in our interviews. So this is just one example. For folks who said the protocol was not easy to remember or access, we created Badgebackers. So every physician has to have a badge. On the back of the badge, we have backers that go on the back of it. The whole protocol is on this 3-inch by 4-inch badge. On top of that, the hardest part about the protocol that we found out was that clinicians said, hey, look, I get the protocol, I understand it. I just can't calculate a Cal scale. Who knows what that is in here? Yeah. So for those of you who know what a Cal scale is, I mean, it's like taking the SAT. There are 12 different sections that you have to walk through, and it takes a while. And to do this in an ER is often not feasible, or it feels like it's not feasible. Often, also, clinicians said, well, we don't actually remember the Cal scale. So we created a QR code. So physicians pull their phones up, shoot, they don't even shoot a picture. All they have to do is shoot the camera, point the camera at the QR code, and the Cal scale pops up for them. For folks who said that it was not top of mind, here's an intervention that we created for them. We created success stories and shout-out emails. So once a month now, our whole department of 300 physician's assistants, ER docs, nurse practitioners gets this email, and it says a couple things. The first is, here's how we've done this last month. And it shouts people out specifically. Lisa, you were excellent last month. You referred 3 patients to treatment. Ben, you prescribed buprenorphine in the appropriate circumstances 4 times. We also highlight success stories. You know, one of the interesting things about the ER is that by definition, you don't see your success. The patients who are in recovery, you don't ever know. And so what we've done is we started to lift up those success stories. And we'll say, Dr. Kennedy, did you know the person you took care of 7 months ago is still in recovery today because of the decision you made? Now, for folks who said it's unclear whose responsibility it is to treat, is it the social worker or the psychiatrist, that Badgebacker I showed you, on the side of the Badgebacker, it's intentionally built wide so that part of it hangs out, and it says, I treat opioid use disorder. It's pretty clear. For folks who are unclear, it's literally what we call in behavioral economics identity framing. but more importantly for others in the community, for patients, for other providers, it lets folks know that this is who is doing the critical work. And lastly, for folks who said that there was a lack of cues to remember, we built an EMR algorithm into Epic, which basically does an analysis of patients' past medical history. And it tries to figure out who is at risk for opioid use disorder. And that Epic flag pops up whenever a patient meets those criteria. And it asks the physician, hey, have you thought about asking this patient about opioid use disorder and whether or not they're interested in treatment? And that's one way that we've been able to answer or address this barrier of lack of cues to remember. Now, remember, guys, this talk is not about Mass General. It's not about me. It's not about GetWaivered. This talk is about the individual power each one of you have and the power that we have as a collective to come together and overcome this. We started with a story. We'll end with a story. I was in the ER. This is maybe about 5 or 6 months ago. And a woman in her mid-30s came in. She was actually a law school professor in Boston. And in her late teens and mid-20s, she'd struggled with opioid use disorder. And because of mounting financial stresses and issues at school, she basically started using again. She'd struggled with ways to get into recovery and did not find a way that worked for her. About a week before she came to see me in the ER, she'd been feeling nauseous, having abdominal pain, and just didn't feel right. So on a whim, she decided to take a pregnancy test. She was right. She was pregnant. She said that maybe there was something about me. Maybe there was something I wasn't seeing that was blocking me from my own recovery. Like sunlight, every time I tried to grasp it, there would be nothing there. But this isn't about me anymore. This is about the future of my son or daughter. And for them, I've got to make this step, this chance, this opportunity to get better count. So she'd heard about our protocol. She came in. She was given buprenorphine that day, and she followed up the next day in specialty clinic. And for the clinicians in the room that like to do this, I'm a little bit of a nerd. I follow my patients. I track them. I've been tracking her for the last 4.5 months, and I'm proud to tell you guys that both mom and baby are well. She's not missed one prenatal appointment, and she's still in recovery. That story is not just about one life being changed, it's the future of her child's life being changed as well, and that is what is at stake here. We are all partners in this work. Things won't get better if we sit on our hands. You're here today because you have a privileged position, no matter if you're a recovery scientist or a journalist or you're a physician or you're a public health expert. We are brought here to do this work together, and the only way that we will overcome this is just like with the HIV/AIDS epidemic, groups coming together and sharing knowledge and thinking about things in a different way. I am your partner in this. GetWaivered is your partner. If you want to reach out, please take your phone out and just shoot. Point your camera at the QR code. Send us a message, an email. Follow us. If you're struggling with a certain issue or if you're hitting barriers, we can help. Thank you guys so much for coming, and thank you for listening.
For just a couple questions, if folks have any questions. I think we're all pretty jazzed about the QR code, actually.
I have a question.
Yes.
So did they need to ramp up outpatient services to accommodate the people from the ER that you were inducting?
That's a great question. So we were lucky enough in Massachusetts and Massachusetts General Hospital specifically to actually have specialists who were sort of ready to accept patients. They just didn't really have a connection to the ER. And so it was really on us as ER doctors to step up to the plate and join the fight to address this opiate epidemic in the way that we could.
I imagine though they had to reinforce some personnel or whatever to do weekend induction visits. I would imagine they probably weren't doing that before.
That's exactly right. That's exactly right. We were initially only, the Bridge Clinic was only open 5 days a week, and it was open from 9 a.m. to about 3 or 4 p.m. And so as we started ramping up, it's exactly as you said, as we started ramping up the numbers of patients, they actually moved to a 7-day-a-week model, and they're actually now open until about 7 or 8 p.m. So. How much time you got? Yes, that's a great question. It depends.
Can you repeat the question just in case
Yeah.
people didn't hear it over here?
Yeah, so the question, excellent question, was is there a waiting period between the last time that someone took an opioid and when a patient can start on buprenorphine? And the answer is absolutely there is. It depends on if it's a short-acting or long-acting opioid. We, at Mass General, if you have a short-acting opioid in your system, it's about 12 hours. Methadone, it gets a lot harder because some methadone can actually last in your system, depending on the way that your body metabolizes it, up to 2 days. So it's really tricky. And for those patients, we would rather sort of keep them, watch them, hold on to them, and then induce them in the ER.
Yes, ma'am.
My question is, did the medical legal department of your hospital come to you and say that the malpractice insurance went up for all of these people prescribing opiates?
No. I mean, I think as it was stated earlier, we are already prescribing opiates. We're already prescribing oxycodone. Folks are already getting MSIR, morphine sustained release. We're already prescribing fentanyl patches. So they didn't come for us for that. And they have not yet, I can't say in the future, but they have not yet come for us. The one interesting thing about our protocol, which I will say, is this, and this gets into a little bit of the strategy. This, from our standpoint, was a political strategy, political organizing effort, quite frankly, right? Who is on our side? Who is absolutely not on our side? Who's in the middle that we can move to our side? Okay? And so what we had the decision of initially was, should we go through the process of getting everyone waivered? Because there's a scenario where you could do this without getting people waivered, right? Particularly folks who work in community or rural EDs. It's not necessarily true that folks need to be waivered, but we made the decision, strategic decision, to get everyone waivered because we knew if there was an issue, if somebody did the wrong thing and precipitated withdrawal, or if somebody gave buprenorphine to the wrong person, or if we had a bad outcome, it would come down on us, and there would not be a ton of people who sort of were ideologically in alignment with this idea, right? So the wavering process actually is important to learn how to administer buprenorphine, but more importantly, it was a way to change hearts and minds, quite frankly, right? Getting people to understand truly that this is a disease that they can take care of. And so we made the decision to do the wavering process to mostly address that challenge of how do you get people to full-heartedly buy in.
You mentioned some follow-up clinics.
Mm-hmm.
Do they have a cost for the patient, and how many do you have?
How many clinics do we have? So I can start with the cost question. So again, coming to the ER and getting buprenorphine in hand is free. The hospital pays for the 2 days worth of medication. And then it depends on insurance, quite frankly. We're lucky enough in Massachusetts to have, thanks to former Governor Mitt Romney, now Senator Romney, he actually created universal access or universal health care. So even if someone doesn't have insurance at our hospital, we get them enrolled in insurance that day. So patients don't pay. To answer the other question about clinics, we have one main clinic. It's called the Bridge Clinic. And the idea is to bridge from the ER to some outpatient setting at some other point.
We do have a teaching hospital system, but of course there are a lot of other hospitals. And I'm familiar with the DEA rule of allowing up to 3 days of administration without getting waivered.
Yep.
Of course, So then the issue is, building that opportunity into getting them into some kind of treatment program within the community. Is that something that Mass General has also done, or is just pretty much everyone shuttled into your bridge clinic and kept within your large system?
It's a great question, actually. Is this we're on record, right? Okay. So we had a patient who came to us from another prominent metropolitan city up in the Northeast. One hospital in particular in that city has been very, very, very instrumental in starting this whole process of wavering. And we have learned a lot, of buprenorphine in the ED. We've learned a lot from this hospital. A patient who was a family member of one of our docs, one of our faculty members, struggled with opioid use disorder and could not get in to that prominent hospital. So that faculty member said, don't worry about it, just come to us, come to Mass General and we'll take care of you here. So we started them on buprenorphine at Mass General and then sent them back to their community. The issue with that is that we don't know that community all that well, so it's hard for us to arrange follow-up. It's sort of on them, to be honest. So we wrote that person we gave them the 3-day home bupe pack, but we also wrote them a week-long prescription to give them time to sort that out. And they were eventually able to get into that clinic. Question was, has there been interest in the psychiatry department, inpatient and outpatient, to implement this protocol? So interestingly, the psychiatrists were the first group at Mass General to be waivered. They had a good number of folks that were waivered, probably about a quarter of their entire faculty. So, what's interesting is that they have not been as ready to sort of accept a whole new swath of patients. So we have used the addiction clinics and addiction specialists. But that's a really great point, that there's a nice alignment between ER and psychiatry in this way. But we've not explored that as much yet. I love that question. Part of what's happened organically is that is essentially what has worked here. And it's really a credit to Dr. Potter. She's a force of nature and has been able to sort of just mobilize an entire state to do exactly what you're saying, which is just a credit to her. I would love to do that. I'm in residency. So I got like 6 more months of residency, and then I'm your man. So if you want to talk more, then I'd love to talk more about how to do that. Just the serious answer is the NIH has the whole GetWaivered protocol on the NIH website, but it's not. There's more than that, right? There's the protocol. Right, exactly. Yeah.
Yeah, I failed. I was so excited to introduce you. I failed to mention that Dr. Martin's a resident. So he is a full-on chief resident right now, doing a lot of things. I wasn't even sure we could get them to...
They let me out of the hospital.
To peel you away, to have you come down here. So we're extraordinarily grateful that he's joined us. Isn't that just amazing testament to the medical education system and training and things like that? So Dr. Gray gets the final question.
Okay.
He's got one more question here. Sir.
Great. Is the DEA here too?
I don't know when this program started. I think it was about 20 years ago, maybe 18. Anyway, when we first got started, the first announcement was the program being offered to teach us the day course over in Houston. So I gave him the $200, went over to Houston, did the course, and sent my paperwork into the DEA. And sure enough, several weeks later, my license came back with X in front of my number. And I kind of sat on it. My patients have all been doctors or members of their family, and I didn't need to prescribe this stuff. I had one doctor that I needed to keep from withdrawing while we got him over to treatment. He wanted to go to California. So I gave him a 2-day supply to get him up there first.
Wow.
Well, one day I came back from work, and there's a white card in my front door. It says, call this diversion official from the DEA,
Wow.
which I did. And she said, Dr. Gray, you've never done this. I said, you're right. He says, you're a pain in the ass. He says, we've got to keep track of everybody that has an X in front of their number. And we've been looking, and we can't find you. He says, you've got to send your thing back so we can take it off and get you off our list. So I sent her the license back. They took it off my list, and I haven't bothered me again. Crazy.
Wow. What year was this? 2012. Wow. Yeah, I mean, listen, I can't speak for the DEA, and I think there are probably some people in here that might be able to speak a little bit more to that. What I can say is that the DEA has some authority to change the way that it promulgates the law. So the law is the law, and we know it doesn't matter what side of the aisle you're on, stuff ain't working in Congress right now. So to change a law, it's going to take an act of Congress, and that's really difficult. But the DEA can actually change the way it promulgates the law, so there's some room there with regard to changing some of the wavering requirements, or it sounds like we have the DEA here ready to speak.
No. Okay, thank you so much, Dr.
course.
Martin. I really appreciate it. Thanks again.